Good evening, and I wanted to thank Mike and the folks from LVAD-parte for this opportunity to present. And I wanted to sort of congratulate or thank all you folks that are joining us. You have to be a special breed to want to hear about circulatory support rather than watch the football game. So we'll try and go through. This has been sort of a labor of love for the data I'm going to show you. I've worked on this project with one of our cardiac surgical residents. We call him Gonzo Gonzalez-Stawinski, and we've been looking at this data on our patients that have been transferred, and I'll try to share with you how we've developed it and what I think is our effort to optimize the hub and spoke network. Now this is sort of our hub and spoke at the Cleveland Clinic. We get most of our referrals and transfers from a 5-state region: New York and Pennsylvania. You see that they put Pittsburgh up front and center in case Bob Cormos was nearby to give him a little bit of a jolt. And I know Layman's here, and we didn't have anybody actually come from Louisville, but from West Virginia, Cincinnati, Indiana, and Michigan. And part of the success of our transfer program has been the willingness of the Cleveland Clinic to accept these folks, but it's really been the effort. I saw Greg over here. Greg's in the back. Greg Price from LVAD-parte, who has really worked with the centers to champion the Cleveland Clinic and to say that if you have a sick patient or you need advice or you're thinking of transfer, to give us a call. And that type of relationship, I think, has been very, very powerful and very successful. One, it provides the referring physician, surgeon, doctor with the comfort that they can call somebody and that we will be available 24/7. And then we learn about how to manage these patients. Now, the hub and spoke concept isn't unique to the United States. In fact, when you look at it, it's basically a trauma response where the patient is stabilized and then sent somewhere for more definitive care. But last week, or a little over a week ago, I was in Singapore at a heart failure conference, and an abstract discussed the use of a centralization of services on the island of Singapore itself. And the region is also looking at centralizing their mechanical circulatory support as they begin to expand into this area. They want to identify centers of excellence, and you can imagine each one of these programs are looking for it. I don't know if you can see, it doesn't show up, but over here, Taiwan did 70 heart transplants last year, which is an amazing number. They're looking to be a center of excellence. Singapore also has a number of heart transplants, and they want to be the hub for all of Indonesia. So the concept is real, and it goes beyond just the United States. Well, with LVAD-parte's help and my nurse clinician's help, we had to train a team to be able to pick up these patients. So we used Metro Life Flight, that's our local life flight services, and they were trained to be able to handle patients requiring advanced life support systems. And it is a collaborative process. This is a mock drill where they have the LVAD-parte console, they have the whole thing, they walk through the whole process from start to finish on how to manage these patients, talking about managing blood loss during the transfer, because often these patients are coagulopathic, airway, oxygenation. The whole thing has been scripted so that they are aware of what we're interested in and what we think needs to be done for the safe transport of these patients. And again, the collaboration is what's made us work. Now, the other thing that we like to think has an outcome, and many of you that are in our mailing area, which probably goes halfway to Singapore, is these outcome books that we send to everybody about every other week. But we do send them with the idea that repeated reinforcement of some of the products and services that we have available at the Cleveland Clinic helps identify, or helps the physician refer the patients. There's phone numbers, there's hotlines, there's 24/7 call lists to get the patient to us. We have another mailing going out specifically looking at acute circulatory support with the idea that when you need help, we're there to help you. Now, we've looked at it, and I think it's important to note the time. This is from 1995 to 03. We looked at the patients from the 5-state region that I talked about that have been referred, and it's important to note the timing because of the opportunities for devices used. And we managed 39 patients, of which the vast majority were post-cardiotomy and 6 were acute cardiogenic shock after myocardial infarction. As you all know, or I think most of you know, the folks at Abiomed know, the lion's share of support systems in the United States is the BVS 5000. And that's when most of ours were transferred on, was the 5000. You can see 17 LVADs, 1 RVAD, 16 BiVADs. I'll give you the quick survival data, which was 30-day survival was 38%. Our overall survival was about 33%. I show you the BVS 5000 because that's what we accepted in transfer. Now these slides I'm going to show you, the next few slides are slides that I put together for an STS meeting that at that time was held every 3 years on circulatory support. And they asked us for me to specifically describe devices for short-term support. So this is a pretty old slide. I think it was 97 or 98. And at that time, these are some of the advantages. Now, I say that knowing that, as Mike mentioned, and you'll be hearing of it from other speakers, that the ventricle has sort of changed the paradigm of how we can manage patients, the duration of support for the patients, and the idea that prolonged support recovery is a possibility with the ventricle that wasn't existent with the BVS 5000. So we've used it, we like it, the nurses like it, we put in an inline oxygenator, which does work, but there are some issues with that on the driving pressure. Overall, it's relatively expensive and it's available. But the disadvantage, as I said in this slide, is we had the limitations of mobilizing the patients, but as Mike said, that limitation back in the mid-90s has been addressed, and there's mobilization possibilities with the new drive console, the need for anticoagulation, and it wasn't at that time a suitable bridge for long-term support, and that was a problem. That was a significant problem. You always had to do something more, or you were forced to shorten your recovery time, and that's where the ventricle has a significant advantage. We use a great deal of ECMO. We probably have 300 to 350 patients with ECMO. This is our typical ECMO support, and I'll show you. This is the venous drainage cannula, the arterial inflow going back, and this is the small pediatric 8 to 10 French superficial femoral artery cannula for distal limb perfusion. Now why I show this is because this is the greatest drawback, I believe, to ECMO support. I have a fellow that is now on the ventricles who originally was supported for post cardiogenic shock after an MI, cardiogenic shock after an MI, and he is now on Monday going to undergo bilateral below-the-knee amputations from limb ischemia. He's 40 years old, and that's related to the ischemic limb injuries of this ECMO cannula and device, and that is one of the biggest side effects of this. This is the ECMO system that we use, and the advantages, as I mentioned, are the easy access, but that easy access has really been the problem, as I mentioned. We have lost so many limbs, feet, transmetatarsal amputations. It's so disappointing. So it is a serious problem. Here's the patients. I put this up specifically because it'll have an impact in our later discussion of what the procedures were before the transfer in the 33 patients, and that's what I want to focus on a bit. They were mostly bypass operations, but you can see there's a listing of very complex operations. Double valves, Ross procedures, redo cabbage, AVR. And this is how our outcomes curve looked with the 39 patients. We had 13 survivors, of which 7 were weaned, 6 required conversion to long-term devices, which were predominantly the HeartMate, and all 6 went on to transplantation in the survival arm. But we had 26 non-survivors. 5 of them died on long-term devices, the HeartMate, from multi-organ failure. But 5 died post-wean, and again, this brings up the question, are we weaning these patients at the appropriate time? Because most of the patients that died post-wean died from low output syndrome, and we're going to look at this further. We haven't analyzed those in detail, but that's a question in terms of the duration of support. We specifically looked at undisclosed medical and social conditions on transfer, and you say, well, how is that undisclosed? Well, I get the phone call, we have a guy, we did a couple grafts, and an aortic valve can't come off pump, he's on a BVS 5000 BiVAD, he's 40-some years old, we'd like to send him up. I'd say, sure, send him up, and then we'd find out when he gets here that his chest is open, he bled 4 units on the way up, he's still coagulopathic. We take him back to the operating room, because I didn't ask a lot of questions. I said, yeah, just send him up. Or that he